afternoon. I'm Bunny Ellerin, the director of the Healthcare and Pharmaceutical Management Program at Columbia Business School. And I'm pleased to welcome you today to today's program, which is being presented by HPM as part of Columbia Business School's Thought Leadership Series, Leading Through Change. Just about a year ago, in April 2020, we hosted a panel of health, logistics, and supply chain experts who, at the onset of COVID, discussed ways to improve hospital management, the best tactics for resource allocation, and the systemic changes occurring amidst the healthcare crisis in the US. We are delighted to welcome back one of those experts today, Professor Carri Chan, who will offer additional perspective and insight a year later. Carri Chan is an associate professor of business in the Decision, Risk, and Operations Division at Columbia Business School. She teaches the core MBA class, Operations Management, and an MBA elective on the US healthcare system. Her research is in the area of hospital operations management. During the COVID-19 crisis, Professor Chan has collaborated with several leading hospitals to provide insights into COVID-19 response planning and has developed evidence-based approaches on how to manage healthcare delivery in resource-constrained environments. Before I turn it over to Professor Chan for her presentation today, which will focus on healthcare analytics and how we can use data and models to predict trends, improve care, and better manage the spread of diseases, I'd like to encourage everyone who's on today's webinar to think about questions and post them. Please post them in the Q&A box, not the chat box. And we will leave time towards the end of the presentation for Professor Chan to respond. So thank you again for joining us today, and welcome, Carri.
Great, thank you for that lovely introduction, Bunny. It's great to be here, and as Bunny said, I do encourage all of you to ask questions along the way. If I'm able to, I'll try to answer them as I'm speaking, and if not, I'll definitely save time towards the end to discuss. So maybe I'll get started, and what I want to do today is talk about kind of this life cycle of how the research I had been doing pre-COVID, how it kind of transformed once the COVID crisis hit, and how things are evolving now, and where I see the future going. So with that in mind, let me just provide a little bit of background to highlight kind of the context and where things lie. So I want to talk about some of the work that I've been doing in analytics, and I'm going to actually talk about some of the early work that I had done pre-COVID. And so this is related to preventative care and predictive models. So right here, thinking about how can we use predictive models to guide care and actually use these predictions to do things in a preventative and proactive manner. I've been working on this agenda, and starting in the summer of 2019, I actually spent a year on sabbatical at New York Presbyterian. And of course, we were trying to pursue this particular agenda when COVID hit. And so through that, there were a number of different analytics projects. I'm not going to have time today to get into all of the details, but what I want to think about and talk about is how actually some of this earlier work that I had done on the preventative care helped provide some insights into ventilator allocations. And as many of you know, there was big fear in that March-April time period, particularly in New York City, that there was going to be a ventilator shortage and that there would be people who needed to be put on a vent and there would not be enough vents, and to think about how to do that. And then I want to also then allocate some time and to see about how this has evolved, and then some of the newer work that is ongoing. And so I'll talk about some of that today as well. So in thinking about analytics and kind of the space of healthcare analytics, we see that relative to other industries, the penetration of the use of analytics to actually guide decisions in some areas are advanced, but in other areas, it's certainly lagging behind other industries. But this is changing a lot. There's more data becoming available, and that has opened up new avenues to use analytics. And so I like to think of the analytic life cycle, I guess. My perspective, oops, let me see if I can get a pointer. All right, is we start with data. We're getting more data that's becoming available. The sophistication of electronic medical record systems is growing. The interoperability of these systems is growing. And so as a result, in the last 5 to 10 years, just the type of data that has become available has increased dramatically. Now, from there, there's been a huge focus and a lot of excitement, rightfully so, on taking that data to guide predictions. Can we say what's going to happen in the future? And so you've likely heard a lot of the buzzwords relating to using machine learning and artificial intelligence in healthcare. And rightfully so, there's a lot of excitement. But what I like to focus on is once we have these predictions, how do we utilize them to guide prescriptive analytics? How do we make decisions based on the predictions we have? Fundamentally, these predictions are only helpful if they actually guide our decisions. Otherwise, it's just this machinery and these numbers that are going on in the background. And I think of this as a cycle because as we incorporate these predictions and these prescriptive analytics, it's changing the way healthcare delivery is done. And so the data and the information that's becoming available is also changing. And so we need to continuously fine-tune the data and the models to get through continuous improvements. So I would say, about 5 years ago, maybe more, I started thinking very carefully about the use of predictive analytics to guide preventative care. And so the motivation is that, the reality is we live in a resource-limited environment, certainly in the healthcare space. We have limited number of clinicians, physicians, nurses, physician assistants. Excuse me. And we also have other types of resources like beds, ventilators, medications, etc. And this capacity is often reserved, rightfully so, for the most severe patients. Now, because data is becoming more available, and there's a growing advancement in the analytic methods that exists out there, we're able to improve upon the predictive models that exist. And so the question that came to me as someone who's been working in the space of healthcare operations for well over a decade is, how can we utilize this information to improve patient care? And in particular, the question that I really wanted to focus on was, how do we use these predictive models to guide proactive or preventative care? There are certain patients that are more at risk than others. We predict patient A is more likely to deteriorate than patient B. Can we give some sort of interventions, some sort of care in a proactive and a preventative way for patient A so that they don't deteriorate? And how do we make these types of decisions? Who are the patients that we focus on? And what are the benefits of doing this? And so one of the motivations and clinical settings where this has been particularly useful, where I've focused quite a bit of attention, is in the intensive care unit. And so I think now in the COVID crisis, the importance of the ICU has come front and center. So there's a less motivation that I need to provide, but these units provide for the sickest patients in the hospital. They're the most unstable. They require constant monitoring. And so as a consequence, these units are often quite full, but they're also very expensive to operate. And so you don't have a lot of excess capacity. Now, there are events called unplanned, I will refer to as an unplanned transfer to the ICU. This is for a patient who is outside of the ICU and they deteriorate unexpectedly. So this deterioration occurs. It evades the normal clinical tracking. And so unexpectedly, they end up having to go to the ICU. There's a lot of data out there that demonstrates these types of unplanned transfers. The patients are much worse off than if they had been admitted to the ICU directly when they arrived in the hospital. So here I've provided just a couple of statistics at the Northern California Kaiser Permanente across 21 of their hospitals to give you some context to understand what's happening to these patients. So I'm comparing two types of cohorts. Patients who arrive to the hospital are deemed very severe upon admission and are directly admitted into the ICU. I'm going to refer to these as direct admits. And then I'm going to contrast that to these unplanned transfers. Upon hospital admission, they were put into a general medical surgical ward, and then they deteriorated and had to be moved up into the ICU. Now, if you compare the predicted risk of mortality upon hospital admissions, those patients who are directly admitted into the ICU, they seemed more at risk of death than those unplanned transfers. So upon hospital admission, the sicker patients are being admitted, and that makes sense. But then when you see the actual outcomes, those that ended up deteriorating have much worse outcomes. So their mortality risk is almost twice as high as the direct admits, and their length of stay in the hospital is more than twice as long. And so this is this type of data kind of initiated this notion of maybe we can utilize this developments in machine learning to predict who is likely to deteriorate and require an unplanned transfer and actually deliver proactive care, admit them to the ICU proactively before they fully deteriorate so that maybe they're going to have better outcomes. And so this is a project that I started a number of years ago with Kaiser Permanente and has resulted in a number of publications that I'm happy to share later. So the development of the predictive models actually turned out with the increase in availability of data did allow for improvements in predictive power. So I don't want to get into all of the technical details, but if for those of you who are familiar with ROC curves, this is comparing the predictive power of different models. And so in red, this is the curve that is the new predictive model that was developed to predict who is going to deteriorate and need to go to the ICU. And we're comparing it to other early warning scores that exist in the literature and the state of the art before the development of this. And you can see the data tells us that this new model has better predictive power. It is more accurate. The patients who are going to deteriorate, we're more likely to catch them. And the patients who are not going to deteriorate, we're more likely to be able to identify them correctly. And so with that in mind, with this predictive model, then the question is, should we start to admit the most at-risk patients into the ICU early? And so here's a tension, right? So the potential benefit is that for the individual patient, if we provide that early care before things get really bad, you may actually need fewer resources to return the patient to a healthy state, and then they can leave the hospital. On the other hand, the ICU is a very expensive resource. We live in this resource limited environment. And so if we're proactively admitting someone before they really need it, and then a new patient arrives, a new very sick patient arrives, it may actually delay the treatment of this incoming patient. And so that could cause deterioration of that new patient. Additionally, there does not exist a predictive model out there that is perfectly accurate. We are not at the point, nor will we ever be at the point, where we can predict the future perfectly. So that means there are going to be some times when that patient that we think is at high risk of deteriorating and putting them in the ICU, they actually never ended up needing ICU care ever. And so again, we used up this very expensive resource unnecessarily. And so there's this tension. How much proactive care should you do, realizing that because we live in a resource limited environment, we can't just give everybody that care. And so our objective was to try to develop a better understanding of these trade-offs. And actually develop an optimal scheduling policy for how to guide these proactive services. So we created a mathematical model, and I'm not going to go into all the technical details, but I want to give you kind of some insight into what's happening. So we could think of this at a high level as essentially two types of patients, right? We have the urgent patients who we know already need to go to the ICU. And then you have these moderate patients who are currently stable, but they're at risk of deteriorating and becoming an urgent patient. Now, we look at the ICU, and there are patients currently in the bed, but a new bed becomes available. All right, so a patient was discharged from the ICU, and then the question is, should we admit the urgent patient, or should we admit the moderate patient? Now, clinically, most people would say, let's admit that urgent patient. We know they need it, they're there, and we should give them high priority. And so we wanted to understand, when are there scenarios where you may actually want to put that moderate patient into the bed? Now, critically, what we're going to be looking at is these dynamics where patients' states are constantly evolving. So I mentioned that these moderate patients, they may deteriorate and become urgent. If the urgent patients have to wait too long for the ICU, they may end up having to go to a different hospital, a different ICU, or in the most extreme case, they may end up dying while they're waiting. Now, these moderate patients actually, while they're waiting, they may get worse and become urgent, or they may get better and leave the system. And so we wanted to try to understand the tension here. So we developed a mathematical model, and the main takeaways are that there are scenarios where providing proactive care can be very helpful. Putting in moderate patients into the ICU before they become urgent can be actually very beneficial in improving overall congestion in the ICU and improving overall health outcomes. And then the two main conditions are, one, it depends on the efficiency gains that you get through this proactive care. So if you give early care to these moderate patients, maybe instead of staying for 5 days in the ICU, you only need 2 days, and then they recover and can leave the system. If you get this reduction, this dramatic reduction in the service requirement, if it's large enough, we say the efficiency gains are high, and this can be very helpful. Now, the other factor that we need is that the predictions themselves need to be fairly accurate. And we keep making these mistakes. If we put people in who never would have ended up in the ICU in the first place, that is certainly going to unnecessarily clog the unit. And so you need to have a prediction model where the errors are sufficiently small, and we can quantify what sufficiently small means in order for this to be beneficial. So we developed some guidelines for when proactive care is needed. And so under the normal operations, on a day-to-day basis, it is optimal from a clinical and operational standpoint to give priority to the more urgent patients. And this is comforting. We want to make sure that those urgent patients are able to be treated. However, there are scenarios, for instance, when you have a huge demand surge, potentially because of a pandemic or a catastrophic event, it actually can be beneficial and optimal to prioritize the proactive care for the moderate patients. Essentially, you can think of this as a triage where we realize that the demand is so large, we have to unfortunately make those difficult decisions about who is going to be able to get care. And so the benefits in terms of being able to make sure those moderate patients are being treated for very few resources and leaving, it outweighs the costs. But there's a challenge of trying to, once we get back to these normal operations, then you can switch back your priority. And so we can see here that these guidelines can help us understand in practice when should we use proactive care and when should we not. So I see a great question in the chat or in the Q&A box from Michael about how we get insurance companies to agree and pay for this proactive care approach. And that is a wonderful question. So I'll answer this twofold. One is that this project initiated at the Kaiser Permanente healthcare system. That was the initial motivation. And for those of you who are familiar or not, they are an integrated health network. So patients buy Kaiser insurance and they get treated at Kaiser facilities. And so they are both the payers and the providers. As a consequence, there is a more of an alignment of the incentives in the sense that if the providers themselves can improve efficiencies, that translates into savings also to the insurance companies, the payers. But more broadly, there's a handful of integrated healthcare systems out there. They're not all like that. I think the idea here is that we can see that there are benefits in doing this. You may not necessarily see it immediately for a single patient, but on average, we actually do see it for those patients because that proactive care does improve the outcomes in the long run for that individual. And so I think that as the increase in value-based care and these value-based contracts come into play, I think that that's really the mechanism that's going to try to, that would help get payment for this type of care. In the current fee-for-service system, it will be challenging. So there's two related questions, and this is wonderful. There's a moral ethical question in using these types of guidelines, and absolutely. So I think first we have to think about the models themselves, the predictive models. Are they being trained on the right data? We do know, and there are many examples in healthcare and outside of healthcare, where because the training data is not representative, there are demographics, there are individuals where the models perform very poorly. And so it is up to us as people who work in the analytics space to ensure that the training data itself is representative of the group at which these models will be utilized. And I think actually the ethical question of following these types of guidelines, and I'll talk about that in some of the stuff we're doing with ventilators, it's so important to consider those factors. And we're working with clinical ethicists to say, you know, from a operational and clinical efficiency standpoint, these guidelines are beneficial in that sense, both in terms of operational, economic, and clinical standpoint, but from a aggregate societal standpoint. And now there are individuals in any of these situations when we are in a resource limited environment that may end up not getting everything. And I think it is crucial, and I think the challenge has been in the healthcare space. Our clinicians, rightfully so, have been trained to do no harm, to do the best for the individual patient in front of them. The issue is that if we throw the kitchen sink at one patient, this may make it more challenging for us to treat other patients as effectively. And so we have this tension that needs to come into play. And so I think what's important is to have the analytics guide us, but also work in collaboration with those clinical ethicists, with those clinicians, to understand the full repercussions of the recommendations we're going to make. So, so that's some of the stuff that's been going on for a number of years in my research, and I wanted to kind of tie this into what happened with COVID. So we've heard early on, there were a lot of concerns about ventilator shortages with COVID-19. This occurred in Italy, and there was a lot of fear that this would translate into the surge in the US. And so there's a lot of questions of how do you make these types of decisions. And so in April of 2020, one of my collaborators from the Montefiore Medical Center up in the Bronx, which was getting slammed by COVID-19 patients, reached out saying, you know, we're concerned about the potential of a ventilator shortage. We want to see if there's anything we can do to try to prevent that from happening. And so they raised that there is a therapy called high flow nasal cannula. You may have seen patients who have tubes stuck into their nose that are forcing oxygen into their nose and into their lungs. This is high flow nasal cannula. And in prior works and randomized control studies, it has been demonstrated that this HFNC that's being used proactively can actually reduce the risk of having to go onto a ventilator for patients with respiratory failure. This had nothing to do with COVID. I mean, so this is pre-COVID, but there were studies that showed that this particular therapy, if you used it before a patient demonstrates a need for a ventilator, the risk of ever getting to a point where the patient needs a ventilator is reduced. And so they wanted to understand, could this potentially be helpful for COVID-19? And so this started to ring bells in my head about this proactive care that we're doing. That if we did that early treatment, the risk of the deterioration is lower. And also if they finally end up on a ventilator or need the care, the amount of time and the resources needed is shortened, and there's potential benefits. And so what we did was we created a model that looked at how the spread of COVID-19. So we created an epidemiologic model of the transmission. We used data on respiratory failure and COVID-19. And so we tried to, we leaned on our clinical collaborators to see the expertise of, you know, how much do we believe that COVID-19 is similar to other respiratory failure and how much of it is different. And so we use that information to calibrate a simulation model to guide different strategies for HFNC and to try to see what is the potential number of lives saved from this. And so we created this simulation model where we had, you know, similar to before, hopefully this is reminiscent of what I was just talking about, is we have these urgent and non-urgent patients. Now, the urgent patients, they need to be put on a ventilator immediately. If they're not essentially within an hour, they're going to die. In these non-urgent patients, we have this question of, we could either put them on this high flow nasal cannula and hope that they get better. We could put them on a ventilator, or if neither is available, they wait and they may eventually recover or they may die. Now, the challenge here is that for the patients, the non-urgent patients who are on an HFNC, if they improve, wonderful. That's kind of the ideal scenario. But if they decompensated and needed to go onto a ventilator, they're actually worse off than if they had been put on the ventilator initially, because there's a delay in getting them the needed care. And so we had this tension of figuring out what was the right thing to do. So we looked at a whole bunch of different scenarios, and we found that if we used this high flow nasal cannula, oxygen supplement to mechanical ventilations, that proactively using this care could actually save 20 to 80,000 people nationally across the US. And if we focus just specifically in New York City, we believed that would be about 3,000 patients. And so it was interesting that in doing this analysis, one of our collaborators on this work is based in Miami, and Miami started to see their surge a couple months later. And I think it was very helpful for her to say, hey, we may get in trouble, but one of the things that we can do to try to prevent us from getting to the point where we have to make these difficult ethical decisions of who gets a ventilator, why don't we try to make sure that we have these high flow nasal cannula machines available? Because this analysis suggests that in doing so, we can save a lot of lives, and maybe the demand for the ventilators themselves will be lower. And so we looked at this at a bunch of different cities using the amount of ventilator capacity. And ultimately, we can see across the board that if you compare the number of deaths without using any HFNC versus using the HFNC, we could see dramatic savings in terms of number of lives. And I think the biggest tragedy of this, and there's many tragedies, but the biggest tragedy of this pandemic is the number of lives that we have lost. And so utilizing these analytic tools can help guide us and make recommendations of how to prevent that. So, the benefit of this, and I love the questions about these ethical challenges and the balance between what is the right thing to do, what's the pushback, how do you balance between, financial, operational, clinical, and ethical considerations. Montefiore, who we were collaborating with on this project, thankfully never actually had to make those difficult decisions of who to give a ventilator to and who not to. They never entered into that situation where they only had one ventilator and two patients who needed it because of a number of things. One, they were using this high flow nasal cannula, so it reduced the demand. Two, they actually were able to procure a number of ventilators, and also through the pausing of elective surgeries, a number of those ventilators were able to be used for the COVID patients. But there was still a concern, and there was questions of, if we see a second wave, what is going to happen? How do we make these difficult decisions? What is the right way to make these types of decisions? And so it turns out that if we got into that crisis mode, New York State has an official triage policy. So if we got into that crisis mode, and if the governor announced that we were in that particular state of emergency, then the hospitals would follow this triage policy. They would prioritize patients according to this policy. And so a natural question is it effective? And why this was a concern is that the triage policy was developed a number of years ago. It's official state policy, and it was developed in the event of a ventilator shortage. Any ventilator shortage for any reason, and wasn't necessarily tailored, or it wasn't tailored to COVID-19. When the policy was developed, COVID-19 didn't exist. So this is a particular algorithm. It is fairly simple in the sense that it is based on a score called the SOFA score that measures the degree of organ failure of a patient. And the way that you would think about it is that patients are split into buckets. Those who are too sick to benefit from the ventilator, those are who are so healthy they don't need the ventilator. And then you have these in between, some that will benefit greatly and some that will benefit a little bit. And so the New York State triage algorithm is basically, if it is deemed that a patient needs a ventilator, they get a ventilator until you reach capacity. And once you reach capacity, they're allocated according to these scores. The ones who are unlikely to benefit, irrespective of being allocated a ventilator, that they would not receive one. And you want to make sure that the patients who are getting the ventilators are going to benefit. And so the value, I guess, of the simplicity is that in crisis mode, it's very easy to evaluate, right? There's a single score that dictates who's going to get a ventilator and who's not. And so we can do this when things are chaotic during in a crisis. So what we wanted to do was evaluate what would happen if the New York State triage algorithm had to be implemented for COVID-19 patients. And so we used data on 807 vented patients from COVID. We try to estimate what the impact would be for these patients if they didn't get a ventilator. And we create a simulation of the New York State triage algorithm versus a first come, first serve, meaning that essentially you give allocation to anybody if until they need it. If you hit the ventilator capacity, then that's it. We don't follow the triage algorithm. We just wait until a new ventilator becomes available. And so this is a plot. We did a sensitivity analysis depending on what is the risk to the patients if they didn't get a ventilator. So at the extreme, the green line is if they don't get a ventilator, they die. And the blue line is if half of the patients who don't get a ventilator die and half that don't will live. And so we looked at what would happen and what was the value of Montefiore being able to increase their ventilator capacity. In fact, so 180 was their baseline number of ventilators. And so you can see the fact that they were able to procure ventilators improved their survival rates dramatically from about 28% at the very conservative estimate, or 30% at the more optimistic, to 33% by getting more ventilators. So one, it was really valuable and beneficial to get those. But what was interesting is we actually didn't see any difference really in survivability between the New York State algorithm and a first come, first serve. And so this guidelines of what to do, it didn't actually seem to be that much more beneficial for COVID-19 patients. So what we are trying to understand is, are there ways to improve upon the current triage guidelines? So one of the things that we wanted to do was we want to look at what is that triage algorithm. So this is ongoing work. We don't yet have an improved algorithm. My PhD student is currently working on this and crunching the numbers as we speak. But I highlighted earlier on that the New York State triage algorithm, the benefit of it is that it is very simple and easy to implement. And so you can actually break it into what's called a tree algorithm. And the way that you think about a tree is that you start at the top of all the patients and you branch. It's a decision tree. So we start at the top and we say, what is that SOFA score? What is the risk, the amount of organ failure of the patient? If it's very high, so high that they're unlikely to benefit from the ventilator, they get low priority. If it's not that high, we then start branching again. And we see, is it moderate? If it's moderate, they're going to get medium priority. If it's a little bit less moderate, they get the highest priority. And if it's so low that they don't even have any organ failure, they get low priority. They don't need a ventilator. And so for us, it was important to have policies that had this simple structure, because again, in the moment of crisis, you don't want to have to sort through too much information. It's difficult to get that data when it's a crisis. And so we want to learn a policy that has this type of tree structure. So an example, and this is a completely hypothetical tree. This is not a statement of what is a better tree. It's just we believe that a tree could look something like this. For example, we start with using this measure of organ failure, and we branch based on it. We know for COVID patients that there are certain factors beyond this organ failure measure that indicates higher risk of severe COVID. For instance, having diabetes, having a high BMI. And so using those additional criteria to enhance the SOFA score, that's just the only criteria used in the New York State triage algorithm, is something that we are working on to help guide for COVID-19. And so this is something that is ongoing. And in this work, our team is, we have myself from the operations side. We have it's a collaborator from the engineering school, the head of critical care at Montefiore, and a clinical ethicist at Montefiore as well, to incorporate all of these guidelines together, the ethics, the analytics, the data, the operational and clinical factors to help guide when these really challenging decisions arise. So that's kind of the lifeline. I wanted to talk kind of very, very briefly about some of the other ongoing work that I'm doing with another PhD student that came out of COVID-19. And so, we see that there has been a increase in demand. And so one of the things that we've been looking at is how to use predictive analytics to do surge planning, which is the plans that hospitals implement when they see a huge mismatch between supply and demand. How do they increase their supply to meet this surge? And so we're looking at using machine learning to guide, to predict the arrivals to the emergency department. And then we use these predictions to determine what are the staffing levels that we want at this base level. And if we need to surge, how much do we surge? And we find that in doing so, we're able to save 8 to 9% in staffing costs while maintaining the same access to care. And so I just want to highlight and summarize and then get to some of the questions that, the value of the data that's coming out and the predictive analytics it's very tangible and real. There's a lot of opportunities where we can use these analytics to improve healthcare delivery, the efficiency of healthcare delivery, the quality of healthcare delivery. And it's been helpful during the current crisis, but there will be other crises. There will hopefully be periods where we're not in crisis. And there's still a lot of inefficiencies in our healthcare systems that the value and the potential of these is really, really important. So, just to summarize, and then I'll get to some of the questions, and I invite you to write more in the Q&A box as they arise. It's an exciting area to be in right now. There's no shortage of work to be done in the healthcare space, but data is becoming more and more available. The community, the healthcare community and industry is the interest in analytics is growing. There's people who are really already fully committed to it, and there are more people who are jumping on board. And so I think that there's a real opportunity to leverage these tools to go from prediction to prescription and improve overall care. So with that, I thank you so much for your attention. I invite you to ask questions. I'll get to some of the ones in the chat box or the Q&A box. But also, feel free to reach out to me. I've included my email here. I'm more than happy to chat with you if you have any thoughts. All right, so let's start. I guess since I was just talking about the triage, I'll go with Ludmilla. I hope I'm not mispronouncing your name. What about anemia as an underlying condition? Yeah, so great question. We actually have data on the chronic conditions of the different patients. And so what we're trying to do is allow them the data to help us learn what are the conditions that influence the triage algorithm. I will say that, as I mentioned to earlier, an importance is training the data from a representative, training the models from a representative data set. So some of the factors that are going to come out are the ones that have been demonstrated to be at high risk, like diabetes and BMI. And these are not the only ones. And I think that as more data about COVID patients becomes available, we can certainly relearn the model. But we need to have, a condition needs to have enough representation in the data for us to understand how it's going to impact risk. And so my recollection, at least for the data set we currently have of the 800 patients, I do believe we have, I'm not positive that we have anemia, but my sense is that we don't have enough representation to say if that's going to raise things up quite a bit. All right, so maybe I'll just go in chronological order. So the question is the system integrated with other healthcare organizations to ensure that patients identified at risk or transferred from other hospitals are treated accordingly? So the model, the predictive model that I was describing to you earlier, is being used real time at Kaiser hospitals, and there's some journal articles that discuss and present how effective it has been there. It does require getting data of patients upon arrival. The nice thing about Kaiser, as I mentioned, it's an integrated system, it's a closed network, and so that data is available. There are a lot of efforts for other hospital systems to basically create similar types of models and do similar types of proactive care. What I would say is that in those situations, kind of that historical data is not going to be as readily available. So full information about chronic diseases is less likely to be available. And so one would need to train a data that is less reliant on those types of chronic conditions. But there's still I think the work, both the empirical and statistical analysis, as well as the mathematical models, are still suggestive that doing this type of proactive care is really beneficial. And so I guess related to that, Anthony is asking, is there an opportunity to integrate these models into electronic health records so they can be used at the point of care? And absolutely is the short answer. So again, at Kaiser, they do have the predictive models integrated into their system. This emergency department work that I very, very briefly touched on, we are in discussions with a healthcare provider to try to implement the staffing model. And we are working with people in the bioinformatics space to do exactly that, to integrate it so that it is streamlined with the clinical workflow. If I've learned anything through various implementations, if it adds too much work to the normal workflow, even if it helps in the long run, there's no hope in terms of getting it to be utilized fully. You know, our providers and our administrators are overrun with various tasks, and so the objective is not to add more, but to alleviate some of the demands on their time. And so we have to be very careful about how we design these approaches to facilitate that. So we see what are the biggest confounders to getting a reliable, high quality model. So I think there's a number of challenges. One is getting access to the right data. There is growing improvements to electronic medical record systems and accessibility of that, but there's still a lot of challenges there. And so I think that that's a big issue. Even if we have data on all the different patients, the type of information that's being collected has different purposes. It's not being collected for our models. It's being collected for financial reasons, right? If for claims purposes, or it's being collected for clinical purposes in those electronic medical record systems. It is not necessarily being collected to help us predict specific events. And so we may need to actually do retrospective data collection. Some of that data that is available is also the fidelity and the usefulness of it can be questionable. For example, in using AI and machine learning in medical imaging, it's still a big and open question of if we're going to train these models to detect things, you know, cancerous cells as an example, it still requires a very manual process of having radiologists read and tag every single scan that's going to be fed into these training models. And that is incredibly cost and time prohibitive. And so that's just one example where getting this data is very challenging. I think things are changing. And so they're going to be alleviated over time, but it is still a great issue. All right, so the question is, how do we update this based on new variants? Yes, so the only way that we could update it is if we collect more data, or if we incorporate a sensitivity analysis, or kind of an underlying assumption of what would change under these new variants. So I think that the challenge is that there's still a lot we don't know. You know, I think I'm fortunate that we have the data from a single hospital system. It is so hard. Again, I guess the root of the theme of today is the need to have good data. And ideally, we'd be able to create a single data set that has all of the COVID patients so that we could utilize these tools. But what often ends up happening is we are using data sets from one institution and another institution, and we're not able to incorporate it. Rightly so, you know, these institutions, these systems want to protect their patient private information, and there's a tension here. And so I think that we have an ongoing challenge, and I guess I pose that as a way to figure out how can we share data while still protecting that private health information, so that we can continue to utilize these tools and get the most representative data sets. I mean, this gets back to the question of, you know, we learn it, we train the models on this particular data, but if that data is not representative of the reality now, it certainly is a risk factor in terms of using it. So, okay. Are there guidelines of using individual patient data to run these predictive tools in real-life settings from a data privacy perspective? So I guess this is related. I think a lot of the questions are about data and what are some of the various criteria. Yes, it is. For better or worse, there do not exist currently regulations on how to do that. If we're using the data for quality improvement purposes, that data can be used. But I think because of these questions of privacy, it makes it challenging to expand the data set itself, because hospital systems are being very careful in protecting that information. And for this work that we're doing, you know, we had to go through a number of different approval processes to make sure that we ensure the privacy of the patient, and that we're using the data in the most ethical way, and that that it's actually necessary to use that data. So Shelby asks if we use, or how do we think about using social determinants in our models? It's an interesting question. Right now, we don't have that information in the data that we have, but I am in discussions with some clinicians about surgery and surgical scheduling, and I think social determinants come into play quite a bit. Certainly with telemedicine, that also comes into play. There's this, if we think about the use of telemedicine, there are people from lower socioeconomic areas that maybe don't have access to smartphones or tablets to do video visits. And so the value of telemedicine, or the availability of telemedicine in a sense, goes down. At the same time, there's this question of whether telemedicine opens up opportunities in the sense that there's a more flexibility, right? So if you have a telemedicine visit, instead of taking, for those who have less flexibility in their work schedules, you can do a quick 15-30-minute visit from your office or wherever you are with a clinician, rather than taking off the entire afternoon to go to the clinic. There's also this opportunity with telemedicine to have like non-work hour appointments. So, you know, early in the morning or late in the evening visits, because actually for providers, there's more flexibility. They can actually do these visits from the comfort of their own home. And so they can open up more visits. And so I think that's an important question that many of the people I'm collaborating with and myself are thinking about. But we haven't yet explicitly incorporated it into our models, and it's something that we're having ongoing discussions. So I guess we are running out of time, and I love the energy, and I appreciate all of your questions today. I invite you again to feel free to shoot me an email. I'm more than happy to chat with you. And I thank you for taking the time today to listen to some of the work that I'm doing. So with that, thank you and take care.